like to call the meeting of the Committee on Health and Human Services to come to order. It's Wednesday, February 21st, 2024. We have two bills on the agenda today. Both of these bills we will be laying over for future consideration. And so the discussion we have today hopefully will be useful for areas where there is disagreement or still work in progress. There will be time for more discussion to take place. It's a finite amount of time. Obviously, we have a deadline on March 22nd to have bills, leave our committee. So there isn't an endless amount of time, but there is more time. So hopefully the discussion today will be helpful to bring out areas of difference, and also hopefully people will be listening for areas where there is agreement or already things that people are in agreement on. First, we will be taking up Senate File 1176. Senator Hoffman, please go ahead and present your bill.
Thank you, Madam Chair and members. And in front of you is the A1 amendment, I believe.
I think it's the A2.
A2?
A2 amendment. Would you like to move that?
I would love to move the A2 amendment.
Members, the A2 is an author's amendment, and it is included in the Senate Council. We would like to move the A2 amendment. All of those in favor, please signify by saying aye.
Aye.
Any opposed? The A2 amendment is adopted.
Madam Chair, I think you're going to have a protocol conversation. I understand there's some senators that wanted to, question the A2 amendment, but I'd be more than happy to go line by line on the A2 amendment in the interest of time, if you'd like.
You can please go ahead and
thank you very much.
Bill.
Well, what it did is the change is the age of the patient regarding vaccine administration at a pharmacy. In the course of the past year, when the legislation was introduced, stakeholders of Board of Pharmacy and the Department of Health have worked with the Minnesota Pharmacy Alliance and a group of 120 plus independent community pharmacy owners and pharmacists. And so what that amendment does is the patient, it gets the 3-year to 6-year things pretty simply in there. And there's 3 things that it does. It's technical correction of the word schedule in order to capture newer vaccines. The second thing it does is it changes that age language that I said to you. The consensus among stakeholders would authorize the all ACIP and FDA approved vaccines down to 6, right? But for this case, down to 3 years. What they did is they moved it back to down to 6 years. So the reason for flu and COVID for toddlers is the practical reality is the physicians at the time was going to send them to get these vaccines administered at a pharmacy anyway, right? And so many clinics don't stock the vaccines. What we saw happening during the COVID piece was that the pharmacist became a great place to intervene and really became a go-to place. Me personally, and for lots of people we know, and the numbers are there. The third thing the amendment changes is the effective date is January 1st, 2025. So there's no lapse in the authority. So with that, this is the bill's first stop, and I realize the Pediatricians Trade Association may not be in complete agreement on the compromise aim language in the amendment, Madam Chair, but like you said, we have some time to work these things out. And really, the system, the people are saying to the system, work with us, be patient-centered, and that's what this bill is all about. So members, I'm here today to enlist your support for the continuation of an incredible story, and that story is really the job that the Minnesota pharmacists, the pharmacy technicians, and the interns have done to vaccinate and test millions of Minnesotans. You hear about the moonshot that the COVID-19 pandemic brought up, and it was really an unbelievable short amount of time it took for modern science to come up with the vaccines that would inoculate humans against the plague of our time. However, the moonshot is not only the payload, that's half the battle. The rocket ship is the other half. And maybe most important part of the mission is when the last administration knew they needed to get vaccine shots in arms across America fast, safely, and effective as possible, they turned to the pharmacists and the pharmacy technicians to get the job done. They were the frontline folks on that side of it, on the vaccination side. They stayed open long hours during the pandemic, to inoculate Minnesotans with millions of vaccine doses. That's that ship that we talk about delivering that moonshot, and it was there. Thousands of pharmacists and trained technicians, along with their health practitioner colleagues around Minnesota, they absolutely turned the tide of this modern plague. COVID-19, by any objective observer and the authorities of the federal government, gave to the pharmacists, trained pharmacy technicians, and pharmacy interns, guess what, folks, it worked. Under the Federal PrEP Act, the 2020 pharmacist, the HHS secretary, authorized pharmacy technicians and interns to vaccinate patients in the U.S. 3 years and older, right, with the COVID-19 and other recommended ACIP and FDA-approved vaccines. They were also permitted to order vaccine ingredient and CLIA waiver and non-lab tests. For the first time in Minnesota history, the trained pharmacy technicians under the supervision of a pharmacist were authorized to vaccinate patients 3 years of age and older. Because they were granted these authorities, we're a healthier population today. So in a sense, Madam Chair, that moonshot we talk about was a success. Now over 56% of Minnesotans receive their vaccinations in a pharmacy setting. 56%. I received my vaccination and my booster in the pharmacy right there in beautiful downtown Coon Rapids, Minnesota, in a Cub pharmacy. And it's amazing to go in and get everything done and also find out that, by the way, I could get my shot at the same time. We cannot go backwards. That wasn't payola, by the way. I didn't mention that. It's not getting... Anyway, we can't go backwards on the accessible vaccinations and the immunizations, and we must not go backwards on why patient testing needs. In fact, our rates are still down since the pandemic when it comes to vaccination rates. We need every able-bodied pharmacist, pharmacy technician, and pharmacy intern to continue the fight to ensure our public health in Minnesota. And so what we're also doing here, Madam Chair, is we're following the lead of 30 other states, right, in the U.S. that have codified the PrEP Act pharmacy authorities. And those states allow pharmacists to provide the routine vaccinations, some well before the PrEP Act authorized those amendments. So there's a couple of folks here on the supporters of this bill, Madam Chair, and I just want to let them walk through the legislation, what it does to Minnesota law, and some authorities in that piece. So thank you very much.
Thank you, Senator Hoffman. First on the list for testifiers, I have Anne Filbrick. Please, welcome to the committee. Please state your name for the record and begin.
Thank you, Madam Chair. My name is Dr. Anne Filbrick. Madam Chair and members of the committee, my name is Anne Filbrick, and I'm a doctor of pharmacy and associate professor at the University of Minnesota College of Pharmacy and Medical School. Our pharmacy school is ranked 3rd in the country. Thank you for allowing me to testify today. You'll have to bear with me a little bit. I have a bit of a cold, but I assure you I am up to date on my vaccines. I have been a pharmacist for 18 years, and I've been in charge of immunization training at the College of Pharmacy for 14 years. I have trained and taught hundreds of pharmacists, pharmacy technicians, and pharmacy interns across Minnesota in both in-class content in the pharmacy curriculum and through separate American College of Pharmaceutical Education, or ACPE, accredited continuing education courses. Specifically, they have learned how to screen a patient's health and medications prior to administration of a vaccine, learned how to counsel the patient during this process, and most importantly, how to correctly administer a vaccination. They are also trained in recognizing and responding to vaccine-related emergencies. Additionally, pharmacists and pharmacy interns get training in evaluating a patient's medical and vaccine history in order to make a patient-centered vaccine recommendation. Through my position at the University of Minnesota, I have seen the great work that our pharmacy workforce has been doing in community pharmacies, clinics, and health systems. Minnesota's highly trained pharmacist and pharmacy technician workforce is doing an amazing job with over 5 million vaccines administered in a community pharmacy setting by pharmacists and trained pharmacy technicians since 2020. You've heard from a previous testifier about what an integral part of the healthcare team our Minnesota pharmacists and pharmacy technicians have been and are today. I want to speak with you today about PharmD curriculum and immunizations administration education students receive. I also want to share with you the requirements and training that a pharmacy technician must complete before they can vaccinate patients under the supervision of a pharmacist. Immunization delivery has been integrated into the PharmD curriculum since 2002, when pharmacists were first given authority to administer vaccines in Minnesota. Pharmacy interns, or students, receive approximately 20 hours on vaccine-preventable diseases, their corresponding vaccines, and vaccine schedules. They get information on precautions, contraindications, and side effects of these vaccines. They are also trained in responding to vaccine-related emergencies, such as fainting or anaphylactic reactions. They also have the opportunity to apply this knowledge through cases and make vaccine recommendations. Finally, and most importantly, they get hands-on experience with administering both intramuscular and subcutaneous vaccines at least 3 times in a laboratory setting, as well as have ample opportunity to apply this knowledge and skills on introductory and advanced pharmacy practice experiences. A corresponding ACPE-accredited continuing education course is available for practicing pharmacists. In 2021, I developed a 5-credit ACPE-accredited continuing education course for pharmacy technicians. As the HHS PrEP Act and this proposed legislation makes it clear that pharmacists are the ones to make actual vaccine recommendation, this course does not focus on those who should receive certain vaccines, but rather focuses on general information about vaccines, including potential adverse effects to share with the patient, as well as storage and handling. This course also includes information on responding to vaccine-related emergencies. Finally, the course culminates in being able to correctly demonstrate both an intramuscular and subcutaneous vaccine. Hundreds of pharmacy technicians have taken this course to date. While not included within the course itself, pharmacists, pharmacy interns, and pharmacy technicians must show proof of taking a CPR course in order to pass the content. I note in the legislation before you today, it would require the language states that a pharmacist may delegate the authority to administer vaccines under this clause to a pharmacy technician or pharmacy intern who has completed training in vaccine administration if, 1, the pharmacy technician or pharmacy intern have successfully completed a program approved by the Accreditation Council for Pharmacy Education, specifically for the administration of immunizations, or a program approved by the board. 2, the pharmacist utilizes and the pharmacy technician or pharmacy intern utilize the Minnesota Immunization Information Connection to assess the immunization status of an individual prior to the administration of vaccines, except when administering influenza vaccine to individuals aged 3 and older. 3, the pharmacist reports the administration of the immunization to the Minnesota Immunization Information Connection. 4, if the patient is 18 years of age or younger, the pharmacist, pharmacy technician, or pharmacy intern informs the patient and any adult caregiver accompanying the patient of the importance of a well-child visit with a pediatrician or other licensed primary care provider. And 5, in the case of a pharmacy technician administering vaccinations while being supervised by a licensed pharmacist, A, the pharmacist is readily and immediately available to the immunizing pharmacy technician. B, the pharmacy technician has a current certificate in basic cardiopulmonary resuscitation. And C, the pharmacy technician has completed a minimum of 2 hours of ACPE-approved immunization-related continuing education as part of the pharmacy technician's 2-year continuing education schedule. These safeguards are all important. We need to pass this legislation. The state of Minnesota needs to build on the great work that's been done to immunize patients in Minnesota against preventable diseases. After millions of vaccines have been administered to our patients across the state in a pharmacy setting, we need to allow Minnesota's trained health professionals to continue doing their job. Minnesotans could lose access to vital immunizations and testing services they trust. We must maintain and improve public health by maintaining the immunization and testing authorities granted under the Federal Public Readiness and Emergency Preparedness Act. Without Senator Hoffman's legislation, pharmacists will lose the authority to order vaccination and point-of-care testing. Pharmacies will lose authority to vaccinate children down to the age of 6, and technicians will lose the authority to provide any type of vaccination. The final extension of the PrEP Act expires December 31st of this year. Please make this happen by supporting the legislation today to make certain Minnesota continues immunizations and testing capabilities in a pharmacy near you, where the vast majority of Minnesotans and their families prefer to have vaccines and non-lab test administered. Please support SF 1176. I would be happy to answer any questions about a pharmacist, pharmacy intern, or pharmacy technician's training and curriculum, or anything you think I may be able to help you provide further perspective. Thank you.
Thank you very much. Next, we have on Zoom Steve Simonson. If you can please state your name for the record and begin your testimony.
Good morning, Senator Hoffman and committee members. Thank you for the opportunity to speak today. I'm Steve Simonson, pharmacist and managing partner of 5 community pharmacies in Anoka and Sherburne counties. 3 pharmacies located in primary care clinics, 1 in a grocery store, and 1 in a long-term care hospice pharmacy. Goodridge Pharmacy has been serving patients since 1884, and I personally have been practicing and caring for patients there for 46 years. I'm here today representing myself and the many other pharmacists who daily help keep Minnesotans and their families healthy. We have a long-time cooperative relationship with the Minnesota Department of Health and the Anoka County Health Department. We work closely with our local physicians and healthcare community, improving public health. We work closely with local physicians and including pediatricians to close gaps in care and improve community health measures. Our pharmacists have been immunizing since pharmacists were first allowed to in 2002, over 20 years ago. Minnesota pharmacists stepped up during COVID crisis. Our pharmacists gave over 20,000 COVID immunizations a year for 2 years. We've refined our skills and improved our workflow to successfully deliver an ever-increasing number of immunizations safely and efficiently. I'm serving on the Pharmacist Mutual Insurance Company Board and have not seen any claims against any pharmacist to date. This would not have been possible without our highly trained and educated coworkers. Our pharmacy technicians, our postgraduate pharmacy residents, pharmacy students and interns are critical in delivering immunizations. Pharmacies delivering immunizations provide improved patient access. Vaccinating down to the age of 6 allows for even better access. Entire families can be immunized at the same time instead of needing repeated appointments with multiple providers. Childhood immunization rates are down, and pharmacies offer a vital access point for patients and their families to improve immunization rates in Minnesota. We can take care of the entire family. They can come to the pharmacy not needing an appointment for each and every family member. Pharmacies are open early, open late, and on weekends. Pharmacists remind the patients that their children need to get their well child visits, and they check the immunization records on MIC, the Minnesota Immunization Information Connection, at the point of care. One of our local pediatricians stated, if anything, it should increase pediatric vaccination rates. She often has families that choose to get a few of their vaccines at a time and then have to come back to the clinic for the remaining vaccines. Having pharmacies who can provide these vaccinations and give parents an additional place to get the remaining vaccines for their kids will only increase access and vaccine completion rates. Our services are very well received by moms and dads. They are extremely disappointed when we cannot serve their younger children with the rest of the family in one visit. We daily get referrals from our local pediatricians and family physicians to deliver immunizations the same day as their clinic visit. Most children 3 and above receive their immunizations in the deltoid muscle of the upper arm, just like the older members of their family. Pharmacists and technicians are trained in giving deltoid immunizations. Pediatricians at our local locations are appreciative about the immunizations we deliver and refer patients daily. In their opinion, they think we actually increase their well child visits. If we had to reduce the number of vaccinations we provide, they state, they could not meet the added demand due to staffing and inventory issues. RSV and COVID vaccines are very expensive, and the stock levels are kept at low levels in clinics. From April through October, they are totally engaged in delivering allergy shots and are stretched thin and unable to give many immunizations and other injections. Without the skills of our highly engaged, trained, and empathetic technicians continuing to administer vaccines, pharmacists would not be able to continue vaccinating efficiently and deliver vaccines every day as needed. Pharmacists are being asked to go in so many directions, and a workflow for technicians help immunize lets them focus on other demands of their job when presented in the pharmacy. Our local medical clinics do not have adequate staffing to deliver as many immunizations that they would like to. During the 2023 respiratory virus season, in addition, immunizing in our pharmacies, we made journeys to where patients live to deliver immunizations. Assisted living housing, long-term care facilities, women's shelters and schools. From Otsego, Rogers, Elk River to Bloomington, Isandi, St. Francis, Lino Lake, Circle Pines, and Maple Grove and Corcoran, wherever patients needed to be vaccinated. With pharmacists leading the way and pharmacy residents, technicians, and interns helping them every step of the way, our pharmacy teams traveled to where seniors live and to schools where teachers work and students attend. We utilized physicians-approved collaborative practice agreements and clear wave testing for strep and flu. Having legislative approval to use these tools and a bill for these services would go a long way in improving care for our Medicaid and underserved patients. Thank you for the opportunity to speak today and support for pharmacists granting the tools we need to continue providing quality care enabled in Senate File 1176. Thank you.
Thank you very much. Senator Huffman, those are the two testifiers that I have listed for in support. Is that accurate?
Yeah, Madam Chair, yeah, and I know Buck Humphrey is here as well to finalize it for if you need it, but in the interest of time, you know, if you want to hear from the folks who are saying, oh my God, the world's going to end because you're letting pharmacists do the shots, I'd be more than happy to let them come up here. So.
We'll move to the other testifiers I have on my list. First, we'll go to Eileen Crespo, and she is on Zoom. Welcome to the committee, and please state your name for the record.
I think they're all.
Good morning. My name is Dr. Eileen Crespo. I've been a pediatrician practicing in Minnesota for almost 30 years, and I currently serve as the president of the Minnesota chapter of the American Academy of Pediatrics. Our chapter represents the pediatricians in the state, and we advocate for the health, safety, and well-being of our patients, Minnesota's children. I'm testifying in strong opposition to the section in Senate File 1176, which lowers the age authorizing pharmacists and pharmacy technicians to initiate, order, and administer vaccinations. Under current law, children go to their pediatricians for their vaccinations, and for good reason. If this section of the bill were to become law and children could go to a pharmacy for their shots instead of at their well-child visits or checkup visits with a physician, the opportunity to identify serious health issues that a pharmacist does not have the training to identify will be missed. Pediatric offices are where physicians who have specialty training identify important issues such as delayed development. We evaluate growth looking at weight concerns such as obesity or inadequate weight gain or lack of growth known as failure to thrive. Children have vision, hearing, and blood pressure screenings to identify issues early and allow for intervention. Also, importantly, physicians assess parent or caregiver bonding and look for signs of possible child abuse or neglect. These are just a few of the countless other benefits of health supervision visits. Important health issues identified are time sensitive, and missing them does a severe disservice to any child. Pharmacists do not have the training to identify any of these issues. Receiving vaccines without a physician visit means many children will likely miss these important opportunities to receive early intervention and address any of these important health concerns. Additionally, almost no pharmacies in Minnesota participate in the state's Vaccine for Children program. Vaccines for Children is a federal program that provides all recommended vaccines at no cost to the participating healthcare providers. This means that our most vulnerable Minnesotans, the uninsured, the underinsured, those on public programs, American Indian children, families who can least afford it, will be expected to cover the cost out of pocket. I want to thank the committee for hearing my testimony and for the author and other stakeholders for working with our group to improve this bill. Minnesota's pediatricians appreciate the amendment to raise the age at which pharmacists can administer vaccinations and for what we think is an intention of the legislation to increase vaccination rates in Minnesota. However, that cannot come at the cost of well-child visits or checkup visits with their physician. I urge members to remove this section of the bill. Thank you.
Thank you. And now in person, I have Laurel Reese. I apologize if I am mispronouncing your name.
You got it.
Oh, good. Welcome to the committee. Please state your name for the record, and then after you've finished testimony, make sure you sign in on the sign-in sheet. Thank you.
Thank you, Madam Chair and members of the committee. My name is Reese. I'm a family physician right here in St. Paul, and I happen to be the owner of the Pediatric Preventative Care Map for mHealth Fairview. I've been in practice for 20 years, and I'm also the current president of the Minnesota Medical Association, and speaking on behalf of the Minnesota Medical Association and our 10,000 member physicians and physicians in training today. I'm here to share our concerns with Senate File 1176. Yes, we want kids to get vaccinated. Yes, we're very concerned about vaccination rates in Minnesota. And yes, we value and respect our pharmacist colleagues. However, this bill lowers the age at which pharmacists and pharmacy techs can administer vaccinations, which could result in fewer well-child checks and interfere with continuity of care in our community. And we don't think that this will positively affect child health in Minnesota, and our children are the future of Minnesota. This is what I do at a well-child check when I see a kid. One line on this very complex grid is immunizations. Everything else is also critical to the health of Minnesota's children. I'm talking about growth, development, screening for mental health conditions, doing a physical exam, and then I also know the kid's history. So I have children in my practice who have had chemotherapy a year ago for a cancer. They can't get certain vaccinations right now. Parents, when they read the forms, I don't know, every time you get a shot, you get that form that says, have you ever had Guillain-Barré? Not everybody really understands all those questions well, but I have the added benefit of knowing kids' health histories, knowing their families, parents' concerns, being able to talk to people about the vaccinations that we're giving. And I think that that's a really big asset in the care of our children. Currently, kids see their pediatricians or family doctors or other practitioners for their health care, and these caregivers have been treating the kids their entire life, since birth. And they can get their vaccinations from a pharmacist or pharmacist technician, but then will they be coming in for their preventative care so that we can help families monitor kids' health? The number of times when parents have brought in completely healthy children and we've found conditions and helped families keep their kids healthy, it's not a small number. Our pharmacists are key members of our healthcare team, and we do value and respect them, but we don't believe that the lower age limit for administering childhood vaccinations is going to improve the health of Minnesota children because of that lack of access to preventative care visits then. And so I do appreciate the amendment to change the age for vaccinations from 3 to 6. And I think that's an improvement, but I do ask that we remove the language altogether from Senate File 1176 and pass the other portions of the bill. Thank you.
Thank you. Next, we'll go to member questions, and Senator Abler, you have something you need to step out, so I just...
Thank you.
Go ahead.
Madam Chair. And so, actually, I think I was the author of the original pharmacist vaccination bill, and it seems like it's worked out pretty well. I think the pharmacists these days are quite highly trained and very knowledgeable, and I think this comes down to a matter of, family choice and, where do you want to go and who do you trust? And I think that having more pharmacists around in Minnesota is a good thing, especially given just the cost of going to many clinics and the high deductible plans that people are in that they have to go to. I know a lot of the well-child stuff is free or cheap, but I just generally support the bill. I do have a question for somebody, and I think it was already mentioned in testimony, but if you haven't heard me mention anything about vaccines, it's just I want informed consent. And so if you find that's useful for your health care, then go get them. But you should be informed. And I think one of the pharmacists mentioned, maybe Mr. Humphrey, that they do provide an informed consent opportunity at that point to go over the contraindications and indications. Is that right?
Senator Hoffman, did you want to answer?
Madam Chair and Senator Able, the answer to that is yes, they also do this. If you look at page 3, line 3.22, not only do they talk about that, they also educate about the fact that if you see line 3.22, if the patient 18 years or younger, the pharmacist, pharmacy tech, or the intern informs the patient and any adult caregiver, the patient, of the importance of a well child visit with the pediatrician and or other licensed primary care provider. And I do want to do some conversation about primary care and medical home along with that too. But it's full of information, Senator Abler. Yes, thank you.
Senator Abler?
Well, thank you. I just wanted to comment that, I would appreciate the concerns by the medical community, and but my concerns are allayed about that, and I think it's a good bill. Thank you.
All right, thank you. Other members, Senator Morrison.
Thank you, Madam Chair, and thank you, Senator Hoffman. I appreciated your ode to vaccines in the beginning of your presentation, probably one of the greatest public health triumphs in the history of humankind. And I also appreciate your kind and generous words to our pharmacists, because they are heroes and very recently have really been heroes. Whatever we can do to make sure our kids are getting vaccinated is incredibly important. You just answered my question, which was, do we make sure that kids and families are being encouraged to get their well child visits? Because while vaccines are important, those 3 to 6, those early years are incredibly important in terms of educating parents, children, and families about the issues that set them up for healthy, long, and thriving lives. So I'm really pleased to see that part of the bill. Thank you very much.
Senator Hoffman?
Thank you, Madam Chair. And to that point, Senator Doctor, I'm glad you brought that up, because I'm going to take you back in a history lesson. In 2001, right, when we really talked about medical home in the nation, Minnesota did something. And Dr. Jeff Schiff created this wonderful system. Then out of that comes the pediatric medical home, right? And that's going to get really looking at the primary docs. What's my relationship, that comprehensive, coordinated, and collaborative relationship that I have within my community? Less than half of the kids, the pediatric kids in Minnesota, have some type of pediatric medical home. So the system isn't even caught up on that. So this isn't about really the well child visits, right, which is a Title V public health entity, right? But instead it's about the immunization. And oh, by the way, these pharmacists who are knowledgeable, wonky people are then sharing that information. So I'm so glad that you brought that forward and you looked at that. But this is not changing a system. This is about enhancing what we know works in Minnesota. So I really appreciate the time in front of this committee, and you're going to lay this over, Madam Chair?
Senator Hoffman, yes, we will be laying it over. Other members, do you have questions? Senator Mann.
Thank you, Madam Chair. I thank you, Senator Hoffman, for the bill. Thank you, Buck, for all the work you're doing with the pharmacists, and thank you to the pharmacists. I would push back on that comment just a little bit. It is about primary care, because immunizations are primary care. People do, I practiced primary care for many years, and I know that people came to my office specifically for their immunizations. And then, oh, by the way, thank goodness you're here, because we have a whole thing of things we're going to talk about, like was mentioned before, right? Mental health and screenings and all that stuff. I remember very specifically one patient who came in, had been healthy, normal his whole life, and then at a preventative child exam, we detected an undescended testicle, which had previously descended and then went back up again. And this is a surgical procedure that needs to be fixed. This would not have been caught at a pharmacy, right? Because we're not doing full physical examination. So it is about primary care. Having said that, I'm very happy to see that the bill went to 6 instead of 3, because 3 to 6 I think is a very important time where physical exams are very important. So I appreciate that part, and thank you for all your work.
Thank you.
Senator
Mayor,
Hoffman.
Thank you. I just, thank you for your work in that. And what I really wanted to point out was that over 50% of our children in Minnesota don't have access to a pediatric medical home. And I think the system we need to take another look at the system now. It was just a wonky thing on that, but I appreciate your work on that, and you're correct. And in this case, I appreciate your statements and your work, Dr. Senator. Thank
you. Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Hoffman, I guess the only question I have is, you kind of said that this is a continuation of what's already existing. The thing I guess that I'm hearing most pushback from pediatricians is that there's an issue with the age and the primary care entry and things like that. Is this different than the current setup, or is this now actually making it safer by moving it from 3 to 6? What's the current thing we're working under, and then what's the difference between this and that?
And Senator Hoffman, maybe you can clarify, what was put in place for the federal act and how that will revert to what was prior to that.
Yep, and the changes in there, and Buck Humphrey can give you a little bit of piece on that, when the PrEP Act occurred and what Minnesota did in the 6 and 3-year-old piece. I'm going to let him explain that timeline.
Madam Chair, members, for the record, my name is Buck Humphrey, and I represent the Minnesota Pharmacy Alliance at the Capitol. Madam Chair, Senator Liskey, in 2020, the Trump administration, Secretary HHS, saw, as has been testified before, that they needed a lot more people to put shots in arms and get this a miracle vaccine out there to take down COVID. Right now, under those authorities that are based off of the PrEP Act, which is actually the legislation that was put in place for emergencies after 9/11, but under the presidential health emergency declaration and then the PrEP Act authorities that were placed or given to pharmacists, pharmacy techs, and pharmacy interns allowed for them to do 4 things that they cannot do under Minnesota law. But in general, allowed them to vaccinate any child in America 3 years or older. To the Minnesota law. The current Minnesota law has an age of 13 or 13 and above for ACIP and FDA-approved vaccinations. We smartly, I think, took COVID and flu down to 6, as was indicated earlier. A lot, if not most, of those vaccinations for flu and COVID are done in pharmacy. What this law does is 4 things. As you heard earlier from one of the testifiers, 3 of those elements are agreed to by all stakeholders, or at least we don't know of any known opposition. And those are, first, to authorize a trained pharmacy technician, as you heard about the training, under the supervision of a pharmacist, a PharmD, a doctor of pharmacy, will be able to continue to do the same vaccinations that they have been doing since 2020. So that's good. So day 1 goes from December 31st, January 1, no interruption. The other thing that this allows for, and it really comes down to being able to pay for the vaccinations and the testing, is for a pharmacist to order vaccination ingredient and ClioWave tests. ClioWave tests are the tests that are done, like your nasal swab, et cetera, that are not lab tests. So those are the 3 things that I think everybody's in agreement on. We worked, or MPA worked, over the last couple of years, and really in earnest in the last year, with the Board of Pharmacy and the Department of Health to get to the consensus language, or compromise language, I guess there isn't some consensus on it, to go to the age of 6. You've heard from senators, doctors, about why it's so important, really crucial, that 3 to 6 year in the well child visit. Just to digress there, we actually think, and you talked about primary care homes, Senator, we believe a trained pharmacist can really be a help to that situation too. We believe that they, and certainly with this language, will be required to talk to their patient about how important a well child visit is, and having a primary pediatrician relationship, a doctor-patient relationship, is paramount to the health of that child and to the health of the population of Minnesota. So we actually think it will be helpful to have families continue to go into pharmacies for their vaccinations. The one little nuance of that is, again, to have 3 and above for flu and COVID, which just makes practical sense. It is my understanding, and I know that you received from the Board of Pharmacy in your packets, that they are in agreement with this. We have one small little thing we need to include in the legislation. We'll do that in another stop. But the Department of Health has also said that they think this is a good place to be at. So, and I don't want to misrepresent anybody, But we think this is a really good bill. It doesn't quite do what we had hoped, which is to continue the exact authorities that we've been doing for over millions and millions of vaccinations with people in Minnesota. And I know there have been a few complaints, but with millions of vaccinations, you're going to have a couple. So that's all I guess I have to say on that. But if there's any questions, I'd be happy to answer them, Madam Chair.
Senator Liskey.
Thank you, Madam Chair, and I think that answers pretty thoroughly what I was looking for, and even maybe a little bit above what I was trying to find, which is great. Glad it kind of helps answer those questions. So I appreciate the bill, and I look forward to seeing the minor tweaks as it continues. Thanks.
Thank you.
Thank you. Any other members have questions? I just had one area that I just wanted to ask a question about. In terms of who pays for the vaccinations, if people are coming into the pharmacy, do parents who are on public programs, I guess, can you go over kind of how the costs are implemented in terms of if you're coming in and you are on a public program, or if you have other insurance, or how that works? Mr. Humphrey? Or
Madam Chair, part of that I will ask gracefully to get back to you on in terms of the actual reimbursement, because if you recall, the COVID-19 vaccine, for instance, has been completely free. We are in a private payment situation, but it would be like any other medication that you're going to receive. And, you know, if you have insurance, hopefully most of us do, you will be asked for your card or what have you, and then you pay it that way. But I also want to say that, just to acknowledge that there was discussion slightly by a testifier about the Vaccines for Children's program. We are very thankful that you all appropriate enough money to put a pharmacist over at the Department of Health to help with that program, but it is a troubled program nationwide. It is trying to give free vaccinations to anybody with children in Medicaid. But I think if you asked not only pharmacists, but pediatricians, it is not an easy program to work with. And so we're trying to work with the Department of Health. States like Ohio, others have just decided to really not utilize the program and pay for their own vaccines. Right now, in many instances, pharmacists are giving those vaccinations for free. They're not getting paid for them, which is a whole other problem that we will talk about hopefully later in this committee.
Okay.
Madam Chair.
Yeah, thank you. That's helpful. I just wanted to find out a little bit more about that. Members, if you have any other questions, I guess for me, I think that having the expanded access is important, and I think that we've seen a lot of benefits from pharmacists and the technicians being able to give the vaccines. I hope there's continued discussion about the specific area, kind of concern areas, and maybe we can see if there's any other modifications or how people feel about leaving it as it's been amended. Senator Hoffman, did you have any other final comments before we lay the bill over?
Madam Chair, I got lots of comments, but I'll save those for another time. I appreciate you hearing this. It really is a continuation. And what the good senator from Anoka, which, by the way, that's where Goodridge Pharmacy is headquartered out of, the issue really comes down to patient choice, parent choice, right? And that's my personal statement on that. But really, I appreciate this conversation, and we got a lot of work to do regarding pediatric medical home, and this is just one way of addressing that. So thank you, Madam Chair and members.
Thank you. And with that, Senate File 1176, as amended, will be laid over for future consideration. Thanks. And now we will move to Senate File 659, Senator Maye Quade. Good morning. Welcome to the HHS Committee for this session. And please go ahead and present your bill.
Thank you, Madam Chair. Good morning, members. Thank you for taking time to hear Senate File 659. I first want to thank you, Madam Chair, and your team for agreeing to hear this bill. I know scope changes, any scope changes, even modest ones that are contained in this bill, require a significant amount of time, and I'm deeply grateful to you and your team for spending so much time on this. Senate File 659 is a short but crucial update to scope of practice for Minnesota optometrists. This bill aligned doctors of optometry's scope of practice with their training and teaching by allowing doctors of optometry to prescribe oral antivirals to treat things like shingles in the eye, which has tripled in about the last 20 years, as is done in 47 other states, including every state surrounding Minnesota. It will allow doctors of optometry in Minnesota to prescribe oral steroids for 14 days to treat things like contact dermatitis, as they can and do in Wisconsin, Iowa, North Dakota, and South Dakota. It removes the 7-day restriction on prescribing oral medications to lower eye pressure for patients with glaucoma. Though used rarely, this is an important medication for those with glaucoma who cannot use eye drops. And it allows doctors of optometry to administer routine injections like to numb surface skin before removal of skin tags or to treat minor eye conditions like an eyelid twitch. You're welcome for not bringing any contentious scope expansions to this committee, including optometrists' ability to use lasers or prescribe Schedule II drugs like fentanyl. Simply put, Senate File 659 will enhance care for Minnesotans, updating their scope of practice. And there's been nearly a decade of discussions, and there's been a lot of demonstrated flexibility and willingness to compromise on the parts of this bill. This bill really is about increasing access to care. The length of time to receive care, the time and money spent is a lot for patients. And with less referrals to specialists, fewer trips to the optometrist or ophthalmologist, and not having to take patient time away from family, this is a really, really important bill to address those things. We don't think even one patient jeopardizing their eye health, let alone vision, is something Minnesota should be known for. On a personal note, I just want to say that this is something my family has experienced, and it highlights the difference between access and distance. As many of you know, my daughter Harriet has had a lot of health issues in her very short life. Last October, she had an appointment with her optometrist for the first time, and she has an ongoing eye issue, and she was referred to her ophthalmologist, and it took 5 months to get seen, and she's going to have surgery this session, so I'll be out for just a day or two. Took 3 more months for her to get that scheduled. I have watched her suffer with this eye condition. She wipes her eye so often that it's become a tic. She uses my hand to wipe it sometimes, like as she learned to walk. She would hold my fingers, and then she presses it to her eye, and it will go away. It's an easy surgery, and it will go away. But as a mom, I have wondered if she could have gotten care faster, gotten an appointment sooner, gotten her surgery scheduled faster in other states, because the only people who can treat Hattie's eye condition in Minnesota are tied up providing care that eye doctors in almost every other state are trained to provide and can provide. It is important that in over 20 plus years of advancement in healthcare and eye care, our patients are able to receive the healthcare that their providers are trained to provide. These changes are necessary to modernize eye healthcare in Minnesota, ensuring patients can receive comprehensive and timely care. My testifiers today will further elaborate on the importance of this bill, address any concerns about education or access to care, patient safety, and provide a proven track record of quality optometry care in Minnesota. And I ask for your support for Senate File 659. Thank you so much for your time.
Thank you, Senator Maye Quade. Now we'll move to your testifiers. The first person I have on the list is Randy Kempfer. Are you, Dr. Kempfer? Please state your name for the record, and please sign in before you leave the table.
Yep. Good morning, Madam Chair and esteemed members of the committee. I am Randy Kempfer, a full-time practicing doctor of optometry residing in Fergus Falls. I extend my gratitude to Senator Maye Quade for introducing this pivotal legislation aimed at enhancing health care in Minnesota. Senate File 659 proposes significant enhancements to the well-being of Minnesotans. Throughout nearly a decade of discussions, the field of optometry has demonstrated considerable flexibility and willingness to compromise on several fronts. Currently, optometrists in Minnesota possess prescribing privileges for topical antiviral medications without limitations. However, this bill seeks to eliminate the 10-day limit on prescribing oral antiviral medications, a practice already adopted by 47 other states. Furthermore, while our scope allows for unlimited prescribing of topical carbonic anhydrase inhibitors and oral CAIs with a 7-day limit, Senate File 659 aims to remove this restriction, in line with the practice in 44 other states. Additionally, this bill proposes allowing optometrists to prescribe oral steroids with a 14-day limit based on feedback received during the 2020 hearing in this committee. This aligns with practices in 44 states, with 35 of them having no limit on the length of prescription. These medications are crucial in treating various eye conditions, safeguarding vision, and improving quality of life. Their administration requires the expertise of qualified and properly trained providers like optometrists who are dedicated to comprehensive eye care. Senate File 659 also includes provisions allowing optometrists to administer legend drugs by injection for ocular conditions, excluding intravitreal injections, which represents another compromise. Currently, 24 other states permit such injections. While the bill doesn't grant optometrists the authority to perform laser procedures or operating room surgeries or administer general anesthesia, it signifies a step forward in modernizing eye health care in Minnesota. Our patients deserve to receive the right care from the right provider at the right time. It is time to update eye health care out of the 90s and keep up with the rest of the country. Thank you all for the time and support of this bill and the eye care of Minnesotans. You will now hear from a few of my colleagues on why this bill is so important.
Thank you very much. Next I have on the list Lauren Hly. Please state your name for the record.
Hi, good morning, Madam Chair, members of the committee. My name is Dr. Lauren Hly, an optometrist from St. Paul and the current president of the Minnesota Optometric Association. We know this bill has been discussed quite a bit lately, so we would like to clarify a few things for you. It's misleading and baseless to claim that optometry training in 2024 is deficient because optometrists don't attend medical school. Optometrists undergo rigorous education, including a comprehensive 4-year program in the eye and visual system, including 10,000 hours with doctoral level training. They also complete 2,000 patient encounters before passing national and state exams. Tattoo artists are licensed to perform injections into eyelids, which is interesting because optometrists routinely manage the complications of these injections. This isn't about attending medical school, but about acquiring the necessary training and certification, which optometrists have fulfilled. In Minnesota, 79 counties have optometry offices, while only 30 counties have ophthalmology offices. And the opposition may argue that access to care is not a problem because 95% of Minnesotans live within 30 minutes drive time of an ophthalmologist, but they overlook crucial details, such as, is the ophthalmologist just there 1 day a month? Are they out of network? Are they booked out for 3 months? Just because you're close to something does not mean that you have easy access. In 2023, the Academy of Ophthalmology released a study titled Ophthalmology Workforce Projections 2020 to 2035 in the journal Ophthalmology, revealing that the ophthalmology workforce is insufficient to meet service demands. The shortfall is projected to worsen by 2035. They mention a rate of 44% increase of new optometry licenses, or a difference of 35 new licenses in the state between 2012 and 2022. If you compare the data from 2018 to 2022, the rate goes down to a 22% increase. Of further importance, since 2012, there have been 5 new optometry schools accredited, so of course there's going to be an increase in optometry licenses. Lastly, we do care deeply about myopia or nearsightedness. It's a disease. But with high myopia comes other disease like glaucoma, cataracts, myopic degeneration, blindness. And optometrists find themselves on the front line of treating the disease in new and innovative ways. This bill would not require every Minnesotan to get eye care from their optometrist, but for those of our patients who know us and have known us for years and trust us with their eye care, it would simply give them the choice. Thank you for doing the right thing for eye care in Minnesota and supporting this long overdue bill.
Thank you, and I'm sorry to interrupt the flow, but I neglected to mention at the beginning of our hearing that we have a quorum present, and so I'd like to make note, we do have a quorum present, and a quorum was present when we took the action of laying over Senate File 1176. And now I have Kate Hollenbach. Please state your name for the record and proceed.
Good morning, Madam Chair and members of the committee. My name is Dr. Kate Hollenbach. I'm an optometrist and I live in the Chowan neighborhood in Edina, Minnesota. I completed my 4 years of optometry school in Boston, Massachusetts, but ultimately my husband, who's also an optometrist, and I decided to move back to the Midwest. A large part of that decision was due to Massachusetts having one of the most restrictive scopes for optometrists at that time. During my training in Boston, I fell in love with the atmosphere and patients at FQHCs, which are federally qualified health centers. And when I found out Minnesota has them as well, and that the scope in Minnesota was more in line with my training and education in comparison to Massachusetts at the time, I couldn't say no. Doctors of optometry provide care in diverse practice settings. I personally serve as the eye clinic director at Open Cities Health Center, and I see patients 4 days a week. Open Cities Health Center is a federally qualified community health center in St. Paul, now the only FQHC in St. Paul with an eye clinic. Many of our patients are uninsured and do not have access to care with ophthalmologists due to lack of health insurance and low income. At Open Cities Health Center, we have been training fourth-year optometry students for over 10 years. These students gain meaningful hands-on experience with a wide range of patients from a wide range of backgrounds and are prepared to enter clinical practice upon graduation. My colleagues and I treat patients with complex medical conditions. We take careful patient histories and treat a wide array of eye diseases. Over the past 2 decades, optometrists have safely prescribed antiviral medications, CAIs, and managed the complications from oral steroids. The current restrictions on prescribing of oral medications are unnecessary and create significant barriers to high-quality patient care. In the clinic where I practice, these barriers risk leaving patients untreated and suffering unnecessarily from treatable eye conditions, some of whom end up in the emergency room, waiting hours to be seen and putting strain on our already very, very busy ERs. When I, a trained doctor of optometry, is 5 minutes down the road, willing and able to help, but however, current restrictions in place make that impossible. Thank you, Madam Chair, and members of the committee for your time this morning.
Thank you very much. Next, we have, there's Dr. Jacob Lang on Zoom is the next testifier. If you could please state your name for the record and begin.
Yeah. Good morning, Madam Chair and members of the committee. My name is Jacob Lang. I'm an optometrist, and I live in Hudson, Wisconsin. I'm grateful for the opportunity to provide my testimony today. I practice in a group MD-OD clinic and hold adjunct clinical faculty positions at the Illinois College of Optometry, the Ohio State University, and Salus University in Philadelphia. It is misleading and unsubstantiated to assert that optometry training and education in the year 2024 is somehow lacking because students did not attend medical school to complete their professional degrees. This is comparable to arguing that dentists and podiatrists should attend medical school instead of their respective training programs. All optometrists complete a comprehensive and robust 4-year program. It includes 10,000 hours of doctoral education specific to the eye and the visual system, along with more than 2,000 patient encounters before taking national and state written and practical board exams. The procedures and services that optometrists are asking to perform are taught in the classroom, integrated in the basic and clinical science courses, developed in labs and workshops, and observed and performed under the supervision of qualified faculty and clinicians. We have affidavits from all optometry schools that are verifying this. My training and experience has provided me with the knowledge and the skills to perform these procedures. As a practitioner in both Minnesota and Wisconsin, I have the privilege and honor of serving patients on both sides of the river. However, it's important to note that the scope of practice significantly differs between these 2 states. Presently, I'm speaking to you from a clinic in Hudson, Wisconsin, where I'm able to conduct the procedures and prescribe the medications as outlined in the bill under consideration. For optometrists practicing in Wisconsin, Iowa, North Dakota, and South Dakota, it's pertinent to ask, does crossing a state line nullify their education and their training? Absolutely not. Our paramount objective is always to prioritize patient safety and safeguard eyesight, regardless of geographic boundaries. Thank you, Madam Chair and members for the committee.
Thank you. And then we have in person, Gina Wesley, and please state your name for the record and begin.
Good morning, Madam Chair and esteemed committee members. I'm Dr. Gina Wesley. I'm a practicing optometrist in my own private clinic in Medina, and I reside in Mount. I have over 18 years of experience of practicing optometry here in the state of Minnesota. Throughout my career, I've collaborated with over 50 surgeons in the metro area, providing preoperative and postoperative care for various procedures. Additionally, I've established referral relationships with these ophthalmologists for managing their dry eye disease patients, including a range of in-office procedures and treatments reflecting the trust and confidence they have in our clinic's expertise. Opponents may raise concerns about our ability to manage complications associated with in-office procedures outlined in Senate File 659. However, optometrists routinely handle preoperative and postoperative complications in our offices, drawing from decades of experience in delicate ocular procedures like removing corneal foreign bodies and sutures, showcasing our proficiency with surgical instrumentation. It's essential to emphasize that all procedures and injections proposed in this bill would occur within the confines of our offices, not involving invasive surgery in hospital settings or outpatient surgical centers, or utilizing general anesthesia. Moreover, the scope of practice for optometrists in Minnesota is strictly governed by our current regulations, limiting procedures to those necessary for diagnosing, treating, or managing non-eye-related conditions as outlined in Section 7. We are not seeking authorization for laser-based or cosmetic surgical procedures in this bill. Optometrists, who provide the majority of primary eye care in Minnesota, have been performing these procedures in other states for decades without sacrificing safety. In conclusion, ensuring your constituents have universal access to comprehensive eye care is not just a matter of health, but a fundamental right that ensures the overall well-being of the communities across the entire state of Minnesota. Thank you, Madam Chair and members of the committee for supporting Senate File 659.
Thank you very much. And that concludes the list I have of your testifiers, Senator Maye Quade. Now I move to the testifiers who have concerns. I have Timothy Olson as the first. And Amanda Maltree could come up to the table as well. Welcome to the committee. Please state your name for the record, and please sign in on the sign-in sheet before you leave the table. So, thank you.
Thank you, Madam Chair. Honorable Senators, it's a great honor to represent my colleagues with the Minnesota Academy of Ophthalmology, and I've been a vitreoretinal surgeon for the last 33 years, just completing my work at the Mayo Clinic. I would agree with nearly everything that was said by our colleagues in optometry, and it may come as a surprise to this group, but we get along quite well in the real world taking care of patients. We need optometrists. They're wonderful providers, and we get along, and we don't work so well when we talk about scope issues. But I had the good fortune of being able to arrange a couple meetings with our colleagues in optometry to discuss these things, and I think it's important to drill down on some of these discussions that we've had so that you can understand some of the issues that we're running into. We oppose the Senate Bill 0659, but we agree with that scope should be expanded. We really do. The first meeting, we listened to optometrists, and my question to them was, what is your greatest frustration? And that was actually voiced in the testimony you just heard, that they can't use oral antiviral medications to treat front-of-the-eye disease. We agree. We agree completely, and it should be expanded for chronic disease. But here's where it gets a little bit not so clean. We want high-quality care in Minnesota, but we don't want a lower quality. Do you want to treat back-of-the-eye disease? And the answer was no. We don't want to treat, for example, there's herpes that affects the back of the eye. We don't want to treat that. But the bill, as written, would permit them to use unlimited oral antiviral medications, which include agents like cidofovir, and others that have a much higher toxicity profile. So while we agree with the expansion that they need, we don't agree with an unlimited scope expansion for issues. And that's just an example. Let's go to carbonic anhydrase inhibitors to treat glaucoma. I've been in practice 33 years. I've only used it once in my life longer than a week. It's not a great drug. People don't like it. It's not a great treatment for glaucoma. We have so many other good ways to treat glaucoma that it's not good. But we agreed to allow that to expand. We agree. We agreed to allow that expand. Unlimited is a different story. The only physician that ever uses unlimited, it should be a neurologist because it's treating a different disease. Now, I want to share an area that we ran into a disagreement on, a clear disagreement, and that is injections. We asked, what would you like to inject? And they said, everything that you inject. There's only, if you look at the limitations around the states, there's only one state that allows unlimited injections in and around the eye, and that's Oklahoma. So we said, what do you want to do after you inject? And they said, remove lid lesions, and that was brought out in the testimony. We got our alarm bells went off because we said that's surgery, and in their statute it says they're not allowed to do non-invasive surgery. So now we're getting confused. What is surgery? What is non-invasive surgery? So we want to introduce surgery by surgeons. We've been working on this language for several years, and because there's now confusion on what is surgery, we don't feel, and nobody I've spoken with feels that somebody who's not trained in surgery should be doing surgery. Removing lid lesions is surgery in our definition. So we need to define that, and that's what surgery by surgeons bill. So in our second meeting, I said, here, we gave them the language. We said, here's our language. We want to make sure that you can do everything that you're currently doing. And I want to make that very clear because it's been circulated that that's not the conversation. We want to make sure that you can do everything that you can currently do that's within the law of the state of Minnesota. Example, light adjustable lens. We said, yes, we'll write a clarification of this. Removal of superficial foreign bodies. Yes, we'll make a clarification. Meibomian gland treatments like LipiFlow. Yes, we'll make an exception. Amniotic membranes. Yes, we'll make an exception. The list goes on. So we're in agreement to allow them to do what they're currently doing, not as advertised, take them back to the 1980s, which if you were around then, we were talking about dilating drops, totally different scope of practice. So we are in favor of elevating the quality of vision care in Minnesota. We're not in favor of decreasing the quality of care by giving unlimited expansion. We agree with a lot of almost everything that was said, except I also practiced in Wisconsin, and that's misleading statement to say that he can prescribe things there that this bill allows, because there are restrictions on prescribing in Wisconsin. I know that. I practiced there. Now, my final comment is I would just guard against lowering quality standards. I think the board at Boeing would regret that they lowered their quality standards. So we want to work with optometry and make quality standards high in this state, and we want their scope to expand. I'm going to turn it to my colleague now.
All right. Welcome to the committee. Please state your name for the record and begin.
Thank you, Madam Chair and committee members. My name is Amy Moultrie. I am a general ophthalmologist and a surgeon. I'm an owner in my small business private practice, which is in Edina, and I'm also an associate professor at the University of Minnesota, where I do eye pathology. So as an eye pathologist, I am the one that reviews under a microscope any tissue or biopsy that's removed from the eye, the eyelid, or the orbital tissues around the eye. And my role is really crucial in diagnosis of cancers, other tumors, infections, and inflammations around the eye. And I'm unique. I'm one of 2 people that actively practice eye pathology in the state of Minnesota. And I also want to emphasize that I am part of a team and work as a team with my optometry colleagues every day, and that neither of us can do our job without the other. And we do have common ground with our optometry colleagues on some of these points in the bill, agreeing that under certain circumstances, there is a place for expanded medication prescribing that could help meet the needs of Minnesotans. However, when I consider what's best for patients and my patients, I have concerns about optometrists performing injections, quote, in and around the eye. And in our talks with our optometry colleagues, they say that their intent with this is to be able to inject numbing medication to remove, quote, lumps and bumps from the eye. However, the language of the proposed bill is significantly broader than what they express their intent to be. But even if we do just consider the intent, I think there's still an issue, and that's because as a pathologist, every piece of tissue that's removed from the body needs to be looked at by a pathologist. And that's because even an expert examiner can have a really hard time telling if something is benign or cancerous just by looking at it. And to illustrate that point on the last slide of the handout you were given today, there's an image on the left, and that is an inflamed clogged oil gland. And there's an image on the right that is a skin cancer called Merkel cell carcinoma, which is more deadly than melanoma. And if you look at those two images, you can see those two bumps look very, very similar. And if you were to try and incise and drain that carcinoma, that cancer, that would encourage cancer spread and be really devastating for that patient. And then if we do think about potential broader applications for the language written in the bill, injecting and stick with numbing medication, if numbing medication is injected behind the eye, we call that a retrobulbar injection, there is risk that it can be inadvertently injected into the fluid that surrounds the optic nerve. That's the same fluid that bathes our brain, and that numbing medication then can actually numb the breathing center of the brain so that the patient stops breathing on their own. If that happens, a breathing tube has to be placed and the patient put on a ventilator to support their breathing until the numbing medication wears off. And I have seen this happen. And luckily, when I saw it happen, it was in an operating room where we were equipped to support the patient. But if that happens in an in-office procedure, as we're discussing, that has really severe consequences. So I just give these examples to say that these are not things to be taken lightly. And that's why, we have been discussing Senate File 3758, which would help define surgery and give us all a better foundation to understand one another when we're discussing procedures around the eye and who is most appropriate to perform them. And then I just want to end by saying that I've been thinking a lot about my motivation and my decision to come and speak to you all today, because I think whenever we are making decisions in our lives, and you most of all, we all have all kinds of influences and pressures, right? And so if I'm sitting in my clinic with a patient, I'm thinking about them, but I've also got time pressures. I have financial pressures as a business owner. I have my family pressures. And in order to tune out all that noise, my guiding light is to always come back to what is best for the patient, to do the thing that is going to give them the best vision, maintain their eye health, and maintain the health of the rest of their body. And if I do that, I know I'm doing the right thing. Sometimes doing that is hard, right? It takes time, it takes effort and energy. But it's also important because these patients, these Minnesotans we're talking about, this is my family, your family, all our loved ones, and they want to be able to see, to grocery shop, to drive, to make art, to read music, to see their grandkids' faces. And so I think we all of us and my colleagues in optometry as well, we have a common goal to really thoughtfully maintain excellent, high-quality eye care that all Minnesotans deserve. And thank you very much.
Thank you. Thank you for your testimony. Next, I have a testifier on Zoom, and Akshay Rao, and I apologize if I have mispronounced your name. Please state your name for the record and begin your testimony.
Thank you, Madam Chair. And no, you did not mispronounce my name. You pronounced it perfectly. My name is Akshay Rao. I am a professor at the University of Minnesota's Carlson School of Management. However, I appear before your committee today in my personal capacity as a patient. A couple of years ago, in November of 2022, I developed a condition described as diplopia, which is double vision. And this followed some post-COVID complications. So I was alarmed, and I contacted my primary care physician's clinic and got in touch with a scheduler and said I would like to see a doctor as soon as possible. And she said, I can get you with an eye doctor in a couple of days. And so I went and saw a gentleman who turned out to be an optometrist. He spent about 2 hours looking at my eye examining it carefully, and essentially threw his hands up after examining my macula, my optic nerve, dilating my pupils, and so forth, and said, I have no idea what is going on. I could offer you new prescriptions for your eyeglasses, but that's not going to really help. I declined that prescription and came back home and contacted my regular optometrist. It took a couple of weeks before I got to see him. And then when I went in to see him, he examined me carefully and said, well, I can certainly address your symptoms by attaching prisms to your eyeglasses, but I strongly recommend that you go see an ophthalmologist. So he recommended one close to my home. I contacted them and was seen in a couple of days. And that ophthalmologist was a little alarmed by my symptoms and recommended that I see a neuro-ophthalmologist, which I did, Dr. Mike Lee at the University of Minnesota Hospital. Dr. Lee was also alarmed by my symptoms and immediately ordered an MRI of my brain, which revealed a thumbnail-sized lesion in my right cavernous sinus. Based on that development and based on my history of sarcoids, he recommended a treatment of a steroid called prednisone, infused intravenously, very high dose of 500 milligrams a day for 3 days. And then that was tapered off. And the symptoms that I had been experiencing, which was the inability of my eyeball to move on the horizontal axis, the vertical axis, and some face pain, which were attributed to 4th, 5th, and 6th nerve palsies, were immediately ameliorated. I apologize, my computer is making some sounds. And I have been perfectly well since then. So my concluding comment is I am going to be eternally grateful to Dr. Lee and the ophthalmologist that I came across in my journey, and I am cognizant of the fact that ophthalmologists have a degree of expertise and knowledge that optometrists do not. Optometrists treat eye-related problems. Ophthalmologists are much more patient-centric and recognize that the eye is a part of the body and the brain has an impact on eye functioning. That is my story. I'm happy to report that I'm perfectly normal now. And if the committee has any questions for me, I stand ready to answer them.
Thank you. Thank you very much. And that concludes our list of testifiers that I have. If Senator Maye Quade could come back to the table, and now we can go to member questions. And there may be questions for various testifiers, but members, do you have any questions? Senator Mann?
Thank you, Madam Chair. Madam Chair, I have the A1 amendment.
And members, I believe the A1 is in the packet. Senator Mann offers the A1 amendment. Senator Mann?
Thank you, Madam Chair. So I work very closely with optometrists all the time. I don't think I could get through my week without talking to one. And they're an invaluable part of the team. Having said that, I do have concerns about the bill as written, especially the IV or the intravenous and intramuscular injection portion of the bill. When you inject something intravenously or intramuscularly, that can affect every single organ system in the body. And so what the amendment does is to kind of clarify what the definition of surgery is, which then would impact intravenous and intramuscular injections as well. I do have a couple questions for any optometrist who would like to answer.
Go ahead.
Thank you, Madam Chair. What kinds of medications do you envision injecting intravenously?
And if you can state your name when you begin answering the question.
Yeah, Senator, Dr. Mann, so with that specifically, that is in regards to...
Can you just state your name for the record? I'm
Pardon
sorry.
me, yes, Lauren Hly. That is in regard to the fluorescein angiography to watch the blood flow in the retina.
Senator Mann?
Madam Chair, thank you. Would you be injecting intravenous antibiotics or intravenous steroids?
Senator, that is not part of the plan.
Okay.
Senator Mann?
Madam Chair, same thing for intramuscular. Would you be injecting intramuscular NSAIDs or intramuscular antibiotics?
Is that really, Dr. Howard?
Please correct me if, Senator, that is not part of the plan.
Madam Chair.
Senator Mann?
So I guess my concern is under the language right now, you would be allowed to do any of those things, which is not even your intent. So I think that there's definitely work that needs to be done on this language. Having said that, the amendment, I think, also needs to be worked on because I think it would have, it would potentially remove something that you're already doing, and that is not my intent. So at this time, I would retract the A1, Madam Chair, but I would like to see some more work done on this language for the reasons that you just stated. Thank you.
Thank you.
Thank you, Senator Mann. Members, any other questions or comments? Senator Utke.
Thank you, Madam Chair, and thank you, Senator Mann, for pulling back on the A1 because that took a lot of my work away. The Post-it notes were busy last night. But anyhow, just some comments on things we've heard here today, and some of what I will repeat, I said on the floor last session when this came up as an amendment, and how this affects us in our rural health care. Access is a huge issue, and what's being asked for in this bill is very valuable to us because I noticed by the one handout that we got that showed our state pretty well covered with service, it's not. Where I live, hour and a half or more, you drive to get some of these treatments that we could get right in town. And, you know, listening to the optometrist before us here today, as they explain what they would like to offer in addition to what they're currently doing, I think is a great service to all of us in Minnesota, whether we're just down the block here, down the street a couple blocks, or out in the rural area. Here in town, you can go a few blocks to a couple miles and get any service you need, where we put a lot of time behind the windshield to get in and do these things. So I would sure like to see this go through. And the previous bill we heard here this morning with the pharmacy and the vaccines, it said follow the lead of 30 other states. Well, I think I heard on this bill 47 other states allow this, 44 states allow this, 44 states allow something else, 24 states do this. We don't need to be the outlier. Let's get on board and do what's right and let these professionals offer the services that they're trained for and that we are going to them to seek those services. So as this moves forward, I hope that we can come to an agreement with the last few little challenges that we've been hearing about this morning, and in the end, we can have a better product out there and let our doctors service as needed. So thank you, Madam Chair, and I look forward to what this comes out to later this spring.
Great. Thank you. Senator Abler.
Well, thank you, Madam Chair, and Senator Mann, thanks for the thoughtful comments you're making about that amendment. And Senator Utke as well, and I talking to Dr. Van Kujik and the other doctor who was here, the first one with his I don't remember your name, sir, I'm sorry, but the very thoughtful comments, I appreciate that. I have sat through more of this licensing stuff than probably anybody else in the legislature, and in the past, when 20 years ago we talked about who can put some kind of salve somewhere or other, I sided with the ophthalmologist, And that time has come and gone, and now I think if I'm leaning on the side of the optometrist, but I'm leaning on the side of what's best. And I hear in this discussion I think a healthy discussion about what makes sense and what do you really need and what do you want and what do you not even intend. And so I see it going that way. And sometimes in these negotiations, and they are negotiations, and then you require us, at least Dr. Mann is actually aware of some of these medications that they're using in practice, but you're asking, those of us who don't do any of that in our daily life, I'll make a prediction. Oh, wait, weatherman, and anyway, but there's no one more qualified. But anyway, so now you're asking us to dig into the roots of your practices and decide what's safe and not. And that's the system. And so we all have to vote at some point. And sometimes one side perceived as the more powerful refuses to negotiate with the side that's perceived as less powerful. I was fearful that was going on, but I don't hear that today. But I just wanted to throw my whatever bit of influence I have into keeping you all in the room and having a sincere conversation to come up with something that's different than what's there today. If I had to vote yes or no, I would vote on the bill the way it is if that choice is there's nothing or this. But I think that it maybe is a little unclear in some points to clarify, and I think with the good intention of the U of M crew and others, we can get a really good project going. I think there's no one better suited than Senator Maye Quade to facilitate that. I'm happy to be part of it if it can be. But this is one of the healthier, controversial licensing conversations, scope license discussions I think that we've had in a good long time. And so, Madam Chair, thank you for having a hearing that you agreed to do. I think this is moving a good way, and I think at the end we can get a bill that could be all green. So thank you.
Thank you. Senator Bolden.
Thank you, Madam Chair, and thank you, Senator Maye Quade, for your work on this bill. I also thank you to everybody who has come to testify today and the work that has gone into this bill. Clearly, it has been a lot, and I appreciate the both practices coming to the table and trying to work through this for really what we want is the best care for Minnesotans. I appreciate Senator Abler's comments about how it is a challenge for us up here to make decisions about the care that you all provide in such a expert way, and the details of that is not known to many of us. And so I think it's important to, for us to gather the data and the evidence as best as we can, and we can look to other states and listen to all the stakeholders and appreciate that. So I have just a couple of questions to sort of get at that data evidence piece, just for clarification for myself. And I'm not sure who is best to answer these questions, so we'll see how we go here. I have just a couple. So on the, there's a slide deck offered by the Minnesota Academy of Ophthalmology, and I note on slides 7 and 8, it looks to me like that is referencing laser eye surgery. So I want to just clarify, is laser surgery something that is touched on in this bill?
Senator Maye Quade.
Thank you, Madam Chair, and thank you, Senator Bolden. To be very, very clear, this is not including laser procedures, and that would not be part of this bill at all.
Senator Bolden.
Thank you, Senator Maye Quade, for that clarification. The next piece I want to just ask about is something that has come up several times. Senator Maye Quade, you referenced this in your comments around sort of the vicinity versus access question, which I think is important, as we've had many conversations in this committee around access to health care, and want to be sure that is in place for folks. And so you referenced challenges for your own daughter in terms of access, and it's been referenced a couple of other times. I wonder if there is data around access, not just like the distance to both a optometrist and an ophthalmologist, but like true access, being able to get an appointment. So is that covered in people's networks? Is there a provider who is there not just one day a week, but how quickly can people get an appointment? Is there any data on that access piece?
Senator Maye Quade.
Thank you, Madam Chair, and Senator Bolden, and I'll look to my experts with me. I can tell you that, and I won't have the data, but it's it's kind of when we think of a continuum of care, so you have acute eye care needs or ongoing eye care needs. My daughter often gets contact dermatitis and conjunctivitis because she touches her eyes so much, and she's almost 2 and she goes to a daycare and it's just a petri dish there. And so she sees her optometrist pretty regularly to treat that ongoing issue, versus the surgery that she'll need, she'll see her ophthalmologist. And so when we think of specialty and, surgery and those kinds of things, and so the access piece is not just about drive distance, but it is about the actual availability, number of times an ophthalmologist might be there versus an optometrist, number of appointments they have available, so on and so forth. And I can look at my experts to see if you have more to add.
Madam Chair, Randy Kempfer, I really don't know of any specific data where you can point to, access wait times. A lot of drive time data is out there, but not the length of appointment.
Madam Chair.
Senator Maye Quade?
I do think the number of ophthalmologists versus optometrists is at 3 to 1, something like that.
Yes, there's.
Mr. Kemper.
Yeah, sorry, Madam Chair, Randy Kempfer. There's right now 1,200 licensed optometrists in Minnesota, and the number I think for ophthalmologists is close to 400. So about 3 to 1. So there are definitely more opportunities to get in to see an optometrist. And usually those are taking care of most of the primary eye care in Minnesota, so they already have that established connection with that provider.
Senator Bolden?
Thank you, Madam Chair. So I have just one more question. Again, sort of trying to gather data and evidence. It was mentioned the other states that are, doing similar things to what is in this bill. I wonder if there is data around the safety piece, if there are events, if there are incidents, injuries, these types of things. Like I'm essentially looking at outcomes of care. Is the outcomes for patients different in these other states where, there's a different sort of scope of practice? What does the data tell us with that?
Can I take this?
Sure.
Madam Chair, Senator.
Ms. Haverly, or Dr. Haverly, if you could go ahead.
May I speak? Thanks. Yeah, so if you compare, the malpractice insurance rates were just released between the years of 2012 to 2024. And it's interesting, they found that in certain states that did not expand scope, there was actually a greater increase of malpractice rates as opposed to states that did increase their scope. We can imagine that insurance companies meticulously research some of the risks before they set those rates. And so it's just very interesting to see that there is no correlation depending on scope and increase or stability of malpractice insurance rates.
And
Senator Maye Quade.
Thank you, Madam Chair, and Senator Bolden, just an addendum, and to add on to that as well. In no state where they've expanded scope has there been a scope rescinding of it, because the track record has been good and there's been no uptick or increase of negative outcomes.
Senator Bolden.
Thank you, Madam Chair. Thank you, Senator Maye Quade. I'll just end with, both professions are part of our healthcare team, and which, I, as a healthcare, member of that team as well, I know the value of having that team, and we all sort of play a different role and work together to, get the best care for patients. And so I hope as this moves forward, there continues to be conversation about what really is, where do we land? Where is the best place for patients with this? And so hope we can keep having those conversations, because clearly both professions are necessary as part of that team and care for patients. So thank you.
Senator Kupek.
Thank you, Madam Chair. I just have a couple of comments to make. First of all, I want to thank also Senator Mann, who is also always a go-to for good medical information. It's always nice to have that. And I will also, echo many of the things that Senator Utke said. Those are absolutely, concerns in greater Minnesota that we hear about. And for Senator Abler, I will also say, previous to meteorology, I did do a little reporting, and in a lot of ways, we are like reporters. We become an expert for the day on whatever this subject is, and we're required to learn and go out about that. And so, on this issue, so I represent an area that borders North Dakota, and talking to the optometrists who live in my district, many of them they're starting to, age out, think about retirement, probably selling their practice on to the next generation. And they want to make sure that on the Minnesota side, we stay competitive with our North Dakota neighbor, where they're allowed to do these things. And we want to keep those businesses, those practices, in Moorhead and the surrounding communities. And this would put them at a great disadvantage, if they can't do some of the same things that they can do, right across the bridge over on the North Dakota side. So, listening to them and my constituents, I know I'm proud to be a co-author on this bill, so I thank Senator Maye Quade too for the work. And this also, I think this legislative hearing is a good example of the kind of work we do. We bring people together and we raise, we can make this bill, possibly a little bit better as well moving forward. And I think so. This has been a great hearing today. So I appreciate everybody who testified.
Thank you. Senator Morrison.
Thank you, Madam Chair. Thank you, Senator Maye Quade, and thanks to all the testifiers. I just have a couple of thoughts and a couple of points. Obviously, I am a fan of optometrists. You'll note my spectacles. I receive quite regular care and trust and respect, and really appreciate my optometrist. I appreciated also Senator Mann's amendment, and I understand why she withdrew it as well. But I do feel like we're a little imprecise when we're talking about surgery in the bill, and that concerns me. And to Senator Kupek's point, we're experts for a day about things that we don't know a lot about. So we should probably be really careful if we're talking about expanding invasive medical procedures. So I feel like we need to talk more about what we mean by surgery, what the definition of that is. I've heard references to post-operative care, which to me would imply surgery. We're talking about expanding intravenous medications, intramuscular medications without any definition, but we have very strict definitions of the kinds of oral medications that can be given. So are we laying over today, or are we? Okay, so I want us to find the peace in the valley on this bill and get to a place where optometrists can do their job and patients are protected. I also really appreciated Dr. Haverly's comment that we always, always, always have to center the patient in these conversations. So I'm grateful to our ophthalmologist and our optometrist, part of the healthcare team, as Senator Bolden mentioned, but those are my concerns that I hope that we can continue to work on.
Thank you. Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Maye Quade, I appreciate the bringing of this bill. It's actually pretty important to me, too. Senator Morrison referenced her spectacles. I'll reference my lack of spectacles for the fact that I also have used an ophthalmologist on top of optometry. In fourth grade, I found that I was nearly blind, not quite legally blind, so I had some pretty serious glasses as a kid, and luckily I've been able to now correct that under some LASIK surgery and things of that nature, so ophthalmology was a big deal too. The interesting part of that subject is that my postoperative care, as you mentioned, was actually controlled by my optometrist, not by my ophthalmologist, because the ophthalmologist had referred me to my general optometrist for postoperative care. So I do find it interesting, the discussion that we've had around, well, what's considered surgery, what's considered surgery care. It all depends on the individual doctors, I think, and that's something that I find very strange, that we're arguing over some of these discussions and what is and what isn't care, and what is or what isn't optometry, and what is or isn't ophthalmology. Because it sounds like some doctors choose to refer, some doctors don't, and right now we're fighting over things that are kind of a weird gray area. And so, yes, we're experts for a day. I agree with that statement, because we don't know everything that we have thrown at us. And so I appreciate that there's going to be some further discussions, and because if we don't get out the gray areas, we won't have a good, concise bill. So hopefully we're going to take back that information and work on these things. So thank you.
Thank you. Any other members have questions or comments? I will just say for myself, we have been discussing this bill for quite some time, and I really appreciate that we were able to have the hearing now, and appreciate that last year we had the discussion, but we allowed ourselves the time now to have a real hearing. And I really appreciate all of those who have come to testify. It's been very thoughtful testimony, and appreciate learning more about the different areas you work in, and some of the things that you think are important in your area of work, and realize that we have to take in the information and try and make assessments based on what we're learning. For me, personally, I see an optometrist regularly, and I see an ophthalmologist regularly, and I know that I see them for different reasons, and appreciate both of their skill sets. I think what I've learned over the past few weeks, just the past few weeks though, is that now I'm getting a better sense of clarity on what areas seem to be still of concern, and also that there may be ways that we can work on the language to come to better agreement on addressing those concerns. So I do appreciate Senator Mann bringing the amendment forward. I spent some time reading it and thinking about, what questions I would have, and I can talk to her and others more about, some of the questions I have about that. But one thing that was very striking was that there are areas of agreement between the amendment and the bill. And so I would really appreciate if the discussion between, optometrists and ophthalmologists can continue, so that you can better flesh out what could be ways to modify the language, so that we are all more comfortable, or some of us can be more comfortable that the changes we're making will improve the abilities of optometrists to be working, in their profession as they see fit, and also, making sure that care for patients is maintained, and that people are accessing the right person, the right title, and the right health professional at the right time when they need it. So I hope that the discussions will continue, and we do have a little more time. Senator Maye Quade, if you have any other final comments you'd like to make, and before we lay the bill over.
Thank you, Madam Chair, and I want to thank all the members for their really thoughtful comments, and for, coming prepared and bringing your ideas and your willingness to have this conversation, and particularly to you, Madam Chair, and your team, because this has been a large undertaking. Even though it is my bill, it probably at times has felt a lot more like your bill for all the work that you've had to do. So I want to I'm deeply grateful for all of that work. The final two things that I'll say is, the first piece is that this bill leaves in place the prohibition on invasive surgery, including but not limited to surgery with lasers. And so all surgery that optometrists cannot currently do, they would still not be able to do that should this bill pass. And so I want to be really clear that there hasn't been confusion in the field about what surgery is, and I would assume that that would remain. And then the last part is I just want to give everybody on this committee and anybody who might be listening our commitment that we will keep working on it to make sure that this gets in the right place, so that the full scope that we see in this bill, which is part of the training and the education of our optometrists, they can practice, and then we have our ophthalmologists who provide really important and crucial care as well, and that the continuum of care for our eye and vision systems are the best in the state of Minnesota. So thank you, Madam Chair.
Thank you, and I appreciate your bringing the bill forward. And seeing no other comments, Senate File 659 will be laid over for possible inclusion.
Thank you.
And members, seeing no other business before the committee, we are adjourned.